United Indian Health Services in Arcata, California. I don't know if I pronounced it correctly. First incorporated in 1970, United Indian Health Services is a tribally owned and governed Indian healthcare service with one main facility and 5 sites in outlying areas. It's been around for 42 years, started with a staff of less than a dozen people, and now it is a comprehensive healthcare provider with more than 200 employees. It's governed by a board of directors that includes Indian community representatives from 5 regions and tribal government representatives from each of the primary tribes and rancherias. And our speakers today are Amanda Colgrove, who is the Health Promotion Education Manager for United Indian Health Services, Chelsea Castiglione, did I get that right?
Close, Castiglione, but thanks.
Castiglione, okay. I keep forgetting that it's Italian, right? So I forget that the G's are often silent. And Robin Johnson, who is an HPE specialist with United Indian Health Services. And I'm not sure who's going to speak first, so I will turn it over to you 3.
Great, thank you so much, Meg. And thank you, Sean, for that great opening. That was wonderful. Hi, everyone. My name is Amanda Colgrove, and like Meg said, I'm the manager for our Health Promotion Education Department. I'm Hupa, Yurok, Karuk, Quinault, and Cherokee. I'm a member of the Hupa tribe here in Northern California, and I use she, her pronouns. And Chelsea, if you and Robin want to introduce yourselves, that'd be great.
Hi, everyone. I am Chelsea Castiglione, and I also use she, her pronouns, and I am the HPE supervisor.
And Robin Johnson does all of our tech stuff on the back end. So you'll often see her on meetings, and she's usually she's the one that created the logo that you're looking at on the left-hand side. And the next slides, you'll see a lot of stuff that she did, put the social media stuff together. So she does a lot of our tech stuff, and she's on here too. But Chelsea and I will be the main ones presenting. And so, yeah, just a little bit about what we've done over the last, I guess, year and a half. I was brought in first as a supervisor. I was on this opioid grant. We had a different manager in our department, and over the last year, he moved into a higher position in our public health division, and so I was able to become manager, and we were able to bring Chelsea on as well. So the first year was work that was done, basically a collaboration between myself and Robin, and then Chelsea joined us this year and just came in full force and really has brought a lot of great ideas and energy to the team of what kind of we were doing already, and being able to add her process to her flair to it as well, which has been great. So that's been our team. And I was thinking about it when Paul asked us to do this presentation last week. You know, it was maybe a year and a half ago, a little over a year ago, that we were on these calls, and I'd introduced myself, and I was just like, I'm the supervisor, and we're here at TOR, and I just got on, and so I'm learning things. And I think the end of that statement was probably like, and I have no idea what I'm doing. But as I look through what we are able to accomplish this last year, I was like, okay, we were able to do some things. And so I guess even when it feels overwhelming, or it feels like maybe you don't know what you're doing, if you look at this, you're like, oh man, that's so much, like what have I done? But really, like, it's just small little steps, and small little steps from people who are just like, well, we don't exactly know what we're doing, but we're going to try our best. And so I think that's kind of what got us to all of these different events that we're able to do. If you want to go ahead and move to the next slide, Chelsea. So I haven't seen it in advance yet, but I know that we started in the middle of COVID. Yeah, so we started just like, you know, with all the restrictions of COVID, we work for a clinic. And so we have a public health nurse that gives us guidance of what we can and cannot do. And we weren't able to meet in person or go out hardly at all. So looking at what some of our objectives are, one thing we knew we could kind of focus in on was social media and just trying to grow a social media presence. So we took some of our educational material that we had just in paper form and tried to translate it into something that would maybe be meaningful or received well through our communities, and just put that kind of, I guess, like more tribal flair on it. And Robin was able to take some of our educational materials and turn into these social media posts. And so we definitely, it was a learning process. I think we learned things like some of the ones that have a lot of the verbiage and words don't get read as much. They get passed by a lot easier. Some of the ones that are just like quicker, snappier, easier to read, or have some like catch phrases that people will share those a little bit more. And anything that has to do with our culture and tradition will get reshared quite a bit. Even as I look at this one, the Angelica root, I know a lot of tribal cultures burn sage, and we do too, but our root is something that is part of all of our ceremonies. And it's what goes up with our prayers. And so even for me, looking at that picture right there inside the abalone shell, that's just good medicine right there. And so we realize that when we can kind of connect with those images, it really is something that means more to our people. And so we've seen that through Facebook and Instagram, those have gotten shared out a lot more than just basic information. So we try to incorporate that as much as possible. And that was something we learned during the COVID outbreaks. Not that it's passed, but we at least have a little bit, we can meet in person a little bit more with masks on. So, but this is what started it all. And you can go to the next one. Opioid Awareness Coalition had already been formed. We call it OAK. And it had been formed previously. They met in person, and it was a collaboration between our public health departments, some law enforcement agencies, some community members, some people with lived experience. They were able to come together and just start focusing on what opioids were looking like in our communities. We'd had some accidental overdoses. Throughout this last year, we've had a lot of accidental overdoses with our youth with some medication that they purchased online. And so we'd had some very close losses, and this coalition had formed around that. But with COVID among us, we were not able to meet in person. So this has converted to mostly online, or all online, which, as you all know, you lose some of the in-person stuff. But because our clinic actually spans over 2 counties, Humboldt County and Del Norte County, it's helped make us make each other more available from across the county lines. And so this coalition was able to continue to meet on a monthly basis. And some of the things that they had asked for when they first were meeting were these things like traditional physical movement, which alternatives to chronic pain, and alternatives to medication. Instead of alternatives, we basically, it's our traditions, right? It's like how we were traditionally meant to move. And so we had some people who are storytellers and also have their own like gyms stuff here come and talk to us about basically what it looked like from the beginning, prior to colonization, what kind of movements we would have been doing out in the mountains, and talked about how that being able to mimic that or still incorporate those movements into our everyday lives can be helpful with chronic pain. That was great. We had someone who's a traditional healer locally come and show us how to make salve from some wormwood and other medicines. People in our area, we realized, didn't know that we have medication-assisted treatment here at UIHS. And so we did some presentations about what that looks like, trying to get information out of what MAT is, and also just reduce some stigma around medication-assisted treatment. And so those are some presenters that we had come and speak to us at OAK. some more virtual activities in the first year. We did some Narcan training, and that was a casino security team had reached out to us, and they were seeing some overdoses and they wanted to be trained. And so we were able to set up virtual trainings with our pharmacists here at UIHS to meet with those different security teams. And we were able to deliver Narcan to them so they could have it on hand as soon as they were trained. And those went well, but they were hit and miss. We learned some things about those. One, people just like it in person a lot better to be able to see specifically how to administer it. So they definitely preferred in person, which we weren't able to do. And they all had their own IT team there. However, there's something to be said that we learned for being able to go to the place and listen to what your system sounds like through their system. So we have our system and it was set up a certain way, and they all had their own systems. But when we got our results back from our surveys, which we did virtually, the sound was one of the main barriers. And so what we learned from that time was that basically, even if we create a Zoom like this right now, we'll do a practice Zoom, we'll have somebody who is there listening, and then someone who is back here doing the online Zoom so that we can know exactly what it sounds like to the people in that room. It seems like a simple thing to say now, but it was something we hadn't thought of. And so things like, even when it started sounding good, they had one of the casinos had our volume turned way up because our sound was very low on their system. But as soon as the video came on, the video was incredibly loud. And so it kind of shocked everybody's ears. And we got a lot of bad feedback about that one. So that was a good learning experience of just listening and get all of your text sorted through ahead of time. So we do that now, even with some of the virtual events we put on. It's a lesson we don't want to learn again. And the bottom part was just some youth summits that we were able to support. There were virtual summits for the youth. The first one, Success in Both Worlds, is a high school native high school native club at one of the local high schools. And they put this on every year, where it's just like, we know that we're here, we know that we operate in this world, but we also have so many traditions and ceremonies and things that we do. That's just kind of giving credit and acknowledgement to youth growing up knowing how to live in both worlds successfully. A youth opioid summit, which was put on by our Yurok tribe, and then another local youth program that put on a health summit. And we were able just to come alongside and support, do some speaking at some of the virtual sessions and provide some incentives. And I think our evaluators also helped with some of the questions. So that was ways we were able to support things that were already happening locally. And from there, we move into when things begin to open up for us for COVID, where again, we would consult with our public health nurse, and she let us know things that we could do when we were out and about. So it would be hand sanitizing, wiping everything down, social distancing, keeping our masks on even when we're outside. And as a public health institution, we don't have masks on right now, but if I get up and walk out or someone knocks on my door and comes in, my mask immediately goes back on. So we'll continue to do that for quite a while. But we're still able to get out and finally go out to some of our clinics and do some outreaches. We have Chelsea, Robin, and I all work here at Padua Health Village, and that's in Arcata. But we have other sites and up from like the north to south, and then out east. So we have other sites, 5 other sites that we're able to go and do outreaches at those clinics who are serving some of our other more rural populations. And things that we took to these outreaches are these medication lock boxes, some fentanyl test strips, the drug deactivation bags. Looks like fentanyl test strips are on there twice, so must have been pretty excited about those. And then we do Narcan with training, a small like in-person training there at the table. So those were all very successful. People really received that and enjoyed it a lot. Some things that we learned along the way. It was in the middle of last summer that the medication lock boxes, which we supply to our pharmacy and to our clients, our distributor ran out completely of these. And at one point we had reordered them and they were checking on the status, and they were like in the middle of some big carrier out in the middle of the ocean. And so we were waiting for this like ocean barge to come in and dock so we could get these sent over to us. And we waited for those for a while, and that was just something that I think couldn't be helped, because that was just when factories were closing down and things with COVID were running rampant. And so we had a little bit of wait time with that. We were able to have Narcan, the nasal spray, most of the time until more recently. We kind of hit a shortage of that as well, but we're working on getting that back. Fentanyl test strips were something that, and the Deterra drug deactivation bags, those two visuals at the bottom, I think were things that I learned at the RX Summit that we went to virtually. And I hadn't heard of those things before. And so we were able to kind of follow up with people who were there and get some orders for those things to be able to be at our table. And they were very well received. Like I mentioned before, we've had youth that were ordering, youth in our community were trying to order things and get pills, and that ended up having accidental overdose. And so for our community to be able to have just some test strips out where they can kind of see where fentanyl was laced in or not, was something that was well received. And then the drug deactivation bags, I don't know if everyone is using those, but it was something that I'd learned about at the RX Summit. And it was just, it's really helpful because people can just dispose of their medication from wherever they are. They don't have to take it into, say, the sheriff's department, where there's maybe some stigma, or they don't have to bring it back. Remember to bring it back to your clinic. You can just put them in the bag and dispose of them there. And so that was well received with a lot of our population, especially our elders, who do have quite a bit of medication and they don't want to necessarily bring it back in. So those all, I think, went really well. I know Chelsea's done a lot of our clinic outreaches here in the last few months. So Chelsea, if you have anything else you wanted to talk about with like successes or roadblocks for clinic outreaches.
I'm trying to think, I think it's been very well received, and we're getting lots of good feedback and lots of great feedback on how else to bring these really vital services to the community. I do want to shout out the question in the chat. Where do we get fentanyl test strips from? I have had a hard time finding them to order. Good question. I'll pass it to Amanda.
Yeah, let me see. I kept calling this the wrong thing, so let me look at so I'll find it before we get off and make sure I'm giving you the right thing. But it's an online company. I think that they have some sort of operations outside of the US, but they can order through Central California. So yeah, that was a different, it was different because even payment wise, our clinic doesn't pay any other country. So finding the fentanyl test strips we could order here in the US was a little bit of a challenge. I think I ended up getting that information from our local public health department. And so someone there had it and passed it on to me. So I think that's another thing, is just being able to collaborate with your local public health department. Like in our county, it was Humboldt County Public Health that was able to give me that one. And I will find that before at the end of this and put it in the chat. And yeah, so these are just some photos we took of our clinic outreaches. Most of them were outside. The one inside was a more recent one, and that's kind of a collaboration of a couple different grants through our health promotion and education department. I just like that it's the inside of Padua. I love all the wood, so I like looking at it. Okay, so our cultural sings. So this was last June, and what happened was, because of the pandemic, we weren't able to do a lot of the ceremony. Families who traditionally have done ceremonies every year for forever, were adhering to the guidance of not meeting and not congregating and not exposing our elders. And so that was one thing that had stopped for 2 years. And it was kind of rough, people who are used to doing ceremony, and your ceremony is for healing. And when you're seeing that the world is hurting and your ceremony is for healing, it feels almost counterintuitive to stop. And so once some of the restrictions lifted, what we were able to do is put on an event where it was outside. And so we had all the social distancing. We just set up chairs so that nobody was too close. And we had masks and hand sanitizer, and we would do health checks before they got there, and we would do temperature checks when they got there. And we were still able to do every Saturday in June at different locations from all the north down to the south and to the east. We were able to do all of a sing at each of our clinic sites. And what that looked like was from each of those different areas, which we service, I think a consortium of 7 different tribes. So there'd be families coming from different tribes and from different ceremony leaders from different families. And we were able to pick or collaborate with people from those different regions and from those different tribes to come together and to lead just basically a circle of ceremonial songs and storytelling, and just kind of getting back together, even though it wasn't a full, like say brush dance, or wasn't a full dance. It was songs from the dances that were able to bring just encouragement to people, healing to the earth and to the people. And so it's something we were able to do still among COVID restrictions, and it went pretty well. It was very well received. Evaluations we got back from the community were very appreciative. They're very thankful to be able to come together and to sing. I think I did pull some of the things they could read, just what they so fulfilled. They felt so grateful for the event. This was good medicine for the heart. They wanted more food. They're used to us like bringing lots of food, but because of COVID guidance, we weren't able to provide anything that wasn't like singly wrapped and stuff. So getting together, not having all the food was a little bit different. But anyways, for the most part, it was really well received. And I think it's something we're going to continue to do. We did it one year. We didn't do it this year because the ceremonies did actually open up, and we're able to do a lot of our dances, and they're happening now. And so next year, I think what we're going to do, what we realized, it was able to help bring some of the ceremonies that are more out in the rural areas into, we're not really urban, but still into some places where not all the natives are able to go out to our different lands and be on the land while it's happening. So bringing it into where people who are more in the cities or on the coast are able to participate was really good. And it also really helped get some of the ceremony leaders and dance leaders just ready for the season again. So I think we're going to try to do it next year and just maybe move it to April so that it's a better time for everyone to kind of get things going again for the dance season. That's something that will continue. Opioid Awareness Day. Yeah, so this was last August, and last year it was International Overdose Awareness Day, the last day of August. It was an international thing. I know that since President Biden came on, he's declared the whole month of August as Opioid Awareness Month. And so that's really great. We had done our clinic outreaches. We combined Overdose Awareness Day with our clinic outreaches. So we'd gone out during that month of August and done this event where we were able to give out coastal redwoods and huckleberries, which are both native plants to the area. And what we did was we created a kind of a response where our community could, it was an anonymous response, and it just says, International Overdose Awareness Day is the world's largest annual campaign to end overdose. Remember without stigma and acknowledge the grief of family and friends left behind. If you have a story, message, or other short response to share regarding your experiences centered on substance abuse, please use the space below to write down your thoughts. And so people would write maybe the story of what they've gone through, or maybe just a message of hope for the community. And anyone who wrote anything on our paper, we'd exchange it for a redwood or a huckleberry plant where they could take it home and plant it, whether in remembrance of somebody or as, a signal of hope for the future. And if they wanted to be completely anonymous after they were done writing, they could cross it out and we kind of like cut it and not use it. And so we were able to get amazing amount of response from people. This is one that we'd worked on kind of growing our social media and like sharing these things out. And this is one thing that kind of just went rampant on its own. Everybody who attended shared it out through their social networks. And so by the time we were getting to clinics, they were waiting for our huckleberry plants, which was really fun. So I know we're going to do that again this year. Robin and Chelsea have plans, I think, with elderberry this year, which is cool because that's a healing medicine that we have, a plant that is local, a native also. And so, yeah, so we have kind of a stack of papers of just what people wrote down for their responses. And I think the next slide has Chelsea went through and picked out some of her favorites. And so I think she's going to share out some of those.
Yes, and I wanted to address the question in the chat too, which is what day is Overdose Awareness Day? Amanda, was it the 30th of August or the 31st?
The 31st. I think it was the last day of August last year.
Okay, last day of August last year, but this year it's the whole month of August.
Yeah, that was because I think it was Australia that had started that, the International Overdose Awareness Day. So it was originating outside of the United States, but we just participated. And then the Overdose Awareness Month is something that is within the United States now. So International Overdose Awareness Day is probably still, yeah, the 31st.
All right. So I just wanted to read some of these. All of them were incredibly powerful, and it was a really good mix of like stories and messages of hope and feelings. And I wish I had time to read you all of them because truly all of them are so beautiful. So my daughter's boyfriend burglarized my house. Months later, he was dead of an overdose. I loved that boy. I believe that local native language learning can assist local youth and elders' pride and healing, a sense of belonging. Addiction sometimes occurs when there is some type of void. Creator, please help those with a void. Fill it with positivity and hope. My brother has overdosed. Narcan has saved his life, and I am so grateful he's still around fighting his disease. We have always been scared to lose him to addiction, and we will always be grateful for it. I come from a family with complex trauma. If you do too, know that you can break the cycle. It might be painful, but it's worth it. The grass is greener where you water it. I love you. 10 months clean today. Addiction is real, but anyone can stop. Reach out. You can do it. XOX. We need to remember to pray for our families on both sides, addicts and those giving out the dopes. These people are our family. So those are just some that I just felt were so powerful and really encapsulate what this means and what overdose has meant in the community.
Yeah, those are great. And there were more, I like that. And those giving out the dope. That's true, both sides, right? We've grown up with it on both sides, so relatable. This I didn't have any visuals for, but I'm just going to talk a little bit because we're here at the clinics, and the things that we're able to do was collaborate between different departments. And that came from Telewell. I think you guys know that, yeah, that Katie Bell was able to kind of just like meet with me a little bit before she retired, and she talked about integration. And so that was something we were able to start looking at with our different departments, our medical side and our behavioral health side, because on our behavioral health side, we have the counselors who are working with our SUD clients and OUD clients and providing support that way. But then on our medical side, we have the providers, the doctors that are actually administering the MAT, the medication assisted treatment, and keeping track of clients on that side. But there hadn't been a lot of integration between the two. And so we just kind of started opening up dialogue between the different departments so we could see basically as our TOR grant, how we could support both. And by asking how we could support both, it opened up some conversation that was really beneficial, I think, to everybody. And so that was one thing we were able to do. And the other thing was just start looking at some of the harm reduction policies we had at UIHS and Narcan. There was one that was already on file, and we were able just to update it. And we updated it with basically what we were already doing. And so it reflected what was current. And from the collaboration and the discussions, we're able to do this harm reduction presentation, which I think maybe had been the first harm reduction presentation at UIHS. Not a lot of people really understood the concept of it, or had a misunderstanding of what harm reduction was. And so through those talks, we're able to have a counselor from our behavioral health department, and then the behavioral health department manager present alongside one of the doctors who is the main doctor that had brought the MAP program here to UIHS. And so all three of those presenters were able to present on what harm reduction looks like and what it could be at UIHS. And we kind of took that information and started rebranding, understanding of what our outreach things look like. And we call them the harm reduction tools that are available to us, so that people really understood, began to understand, I think, what harm reduction could look like. And just trying to help reduce some stigma of what they maybe thought it was. This is you, Chelsea.
All right, I am so excited to talk to y'all about the Tribal Opioid Summit. So this happened this year in April, and it was just it's a virtual event where we had lots of people from all across the nation come in and hear and discuss on different topics. One of our main focuses was trying to make this super interactive, or as interactive as Zoom can be, you know. So we had a panel that discussed opioid use disorder services and youth and the law. Out of this came some really interesting discussions, especially about consent for medication-assisted treatment. So youth under 18 can consent to their own like therapy and things like that relating to SUD in California, but they cannot consent to their own medication-assisted treatment. And so there's a really great discussion on different practices that people have and what different people are doing in terms of that. We had Dr. Claridina Soto from USC come, and she discussed a lot of different data from the California Native Needs Assessment, and then from other different sources. But more than that, this led into a really beautiful discussion on how to address this, so how different communities all across the nation and all across California were addressing what was outlined in the needs assessment. We're addressing some of these data gaps. We're addressing some of these kind of more data-y issues. And so it went from that, what is happening, to the practical on the ground, here's how we do it. And then we had one of our very wonderful nurses / traditional healers, Valerie O'Rourke, came, and she talked about Indigenous pain management. And she does, I don't want to say it wrong, but it's like pressure points to relieve pain and movement to relieve pain and traditional pain management. On the next day, we had Dr. Corey Waller come out, and he discussed the neurology of addiction, so addiction in the brain, kind of his shtick there, which was really good. I think that was a big draw for people to have that big name, but then also, you know, it was great because we were able to really highlight a lot of Indigenous voices with having that big draw and get that bigger audience for all of our information. So I think that was a really positive aspect of that. One of our favorite presentations was Arlene Brown and Jessica Smith did a native harm reduction presentation. And so Arlene is from Bishop, and Jessica Smith is from the National Harm Reduction Coalition. And they came together and indigenized this presentation. And Arlene shared out some really incredible successes from her program and how to meld and really highlight cultural aspects of harm reduction and bring that in to practice, and gave some really great suggestions. This was really also wonderful because it was their first time kind of premiering this presentation. And this presentation is something that they are going national with and doing in all sorts of different venues. So we were really honored to have them present at our Harm Reduction Summit. And then Dr. Waller finished up with a discussion on medication-assisted treatment. From there, we did another more specialized presentation for our staff here at United Indian Health Services. So we surveyed our staff, medical, behavioral health, education, and said, what do you need to know about and we have this national expert. What do you want to know about? And the things that came out of it were MAT and pregnancy and postpartum. Here we have a program for our community health representatives where they interact with folks who are pregnant and experiencing addiction or have someone experiencing addiction in their household. And so we really wanted to figure out how to bring in MAT for folks who are pregnant and or experiencing postpartum, MAT for folks who are in that demographic and how to best serve them in practices. Our staff also really wanted to know about folks with dual diagnoses and how to best serve them. So folks who have a mental health diagnoses and experience addiction, which is a lot of clients, right? Which is a lot of clients. And so how to best treat that and how to best help people get support and care that they need. And then of course, we live in a very, very rural, very remote community. And so we had a discussion on opioid use disorder in rural communities and kind of ways to bridge that gap and ways to help folks and reduce barriers. One of the most interesting things that I thought came out of this was Dr. Waller had a statistic about if someone lives a 20-minute drive or more away from where they're getting a treatment or a service or have their appointment, what have you, then their rate of participation drops off a lot. And it doesn't matter how many miles it is, it's just that 20 minutes, which was really interesting to me. So this was for our staff, and I thought it was beneficial. Some of the successes out of this is I thought like all of our summit was as interactive as we could make it. There was a lot of really good discussion, and it really like highlighted and focused on successes and positivity in Native communities that address opioid use. And so I think that was like a really big positive. Some of the challenges, like of course we had some tech challenges, we had some challenges scheduling with presenters and like getting the schedule right. And so I think if I could take that out and like tell someone if they were going to repeat this, I would say, really check in with your presenters on the scheduling and present very specific times to them. And then one of the other aspects was the just general coordination throughout the summit. And that was our summit.
You want to talk about what this looks like right now?
Sure. Sorry, I didn't know that was you or me. Yes. So right now we're continuing our collaboration and partnership with our behavioral health counselors to support clients in recovery. I'm so excited about this. We have some incentives for folks for attendance. And so to kind of incentivize their participation, incentivize them coming, or to incentivize like really brave things like sharing stories or participating in a cultural activity and things like that. We also know and have learned that transportation is a huge barrier. Gas at $7 a gallon is a huge barrier to people getting here. Our bus systems in our rural community are not the most efficient. And what could be a 15-minute drive ends up being an hour bus ride. And so we offer gas vouchers for clients when they come to their appointments. This is just to help get them there. Or, if they've got a friend who's bringing them, help get the friend gas. And we've seen that that's been really helpful to get participants to various different activities, including like group therapy. And then there's a lot of educational and cultural materials that we're providing. So we're providing beads for beading classes, various different things like curricula, and we are providing stuff for sweats. And so we'll be providing things like the wood or any kind of materials needed for things like that. So really helping support our behavioral health department and help support their kind of vision for all of these different wonderful activities. It's been a really great collaboration and has helped, us bridge some of those services or has helped us actualize some of the things that they wanted to do, but maybe didn't have necessarily the means to do before.
Yeah, it has been really great working with our counselors and for them who are working with the clients, because a lot of people who are in recovery are also some of our knowledge keepers, and so they're able to utilize what they know and what they want to bring to the classes, and whether it's beading and beadwork or learning how to tie ropes and knots for the different sweat houses that we'll be building. all of those things can also be coming from some of our clients who have some amazing knowledge. So this really did come from us being like, this is the grant that we have. These are the things that we're able to do. How can we support what you're already doing? And the behavioral health counselors are really the ones that are like, great, we can use this, we can help. And so when we've been working with them for this last year pretty well. And when I talked to Paul about doing this presentation, I just sent a quick email out to a couple of them just saying, hey, is there anything you'd like to share about how this grant has helped your specific, your program, your counseling? And I got one back really quickly from one of our counselors, and I'll just read out what she said because it was great. I didn't know to ask, and so I didn't find any of this out until the end of last week. So she just replied and said, yes, it has helped us with increasing client attendance. When the incentives came out, one of our clients had a 66% attendance, and after we started the attendance incentives, they increased to 91%. The clients are more engaged in Red Road because they have their own books and study workbooks, which they take home and are able to work on at home. When we go through the 12 steps again, they can see their growth by rereading their old answers. It also gives them a sense that they are important. It also gives them a sense that they're important because they get to keep the books. So far, nobody has lost their books. Sometimes they forget, but they have never lost. The clients have a sense of worthiness to have programs built for them and to have funds written in for them, especially with the new peer support work we're doing. The class with the highest attendance is beading, and we've been able to teach them peyote stitch and working on round wrapping. Soon other traditional regalia tool making, which they always desire cultural teachings. We use the incentives to get them to take healthy risks and do a presentation to share recovery stories with peers. And the last one is clients share what activities we have been doing in aftercare, such as silkscreen, wood burning, gardening, and others want to graduate and become a member of aftercare. We have 4 new members this year. Last year, we only had 2. And so it was great to hear back from her just how it's been benefiting their clients specifically. You want to go to the next slide? Oh yeah, so this is you, Chelsea.
All right. I am so happy to talk about like where we're going with TOR and what we're kind of working on right now. So our first thing that we are doing, and this is just kind of a preliminary, it's not our final, is a billboard with medication assisted treatment messaging. A lot of folks don't know that we offer medication assisted treatment here at United Indian Health Services. And so we really wanted to highlight that. We have some amazing providers who go out into remote areas, where transportation is an issue and provide our medication assisted treatment services at those locations. And so it's just a great service. And we are going to put this in a prominent area in our kind of main city, which is Eureka, and that main like thoroughfare downtown kind of area, and hopefully really get the message out there that this is out there. And it's hopefully that going to have like a positive and just warm, welcoming approach to it too, because we know that we face a lot of stigma in our community about folks coming and getting treatment and about folks coming in to seek help. And so we're hoping that this just has a really welcoming, really low barrier kind of messaging. The next thing that we are doing is that we're so excited and pleased to be partnering with White Bison, and they are going to come out and provide us with a training on their Medicine Wheel 12-step program. And so they're going to be coming out in September and working with educators, but most excitingly, they're going to be working with some peers and some folks who are interested in doing peer recovery support groups. Yay! And some folks who are educators and therapists, and really just a big, and we have a couple elders who are joining us. So a very wide, diverse group of folks who are all interested in providing recovery support services. But not just that, we are inviting our local cultural leaders, so leaders in language, leaders in different traditions like drum making and beading and sweats, and just various different cultural leaders from across our tribes here to take the curriculum that White Bison has, take the medicine wheel 12-step and adapt it to local culture and make sure that it's really fitting local needs and it's really in alignment with local beliefs and local customs. And so we're so excited to do that. White Bison is going to come out for 3 days. And then on the 4th day, we are going to have our local traditional leaders lead us in discussions and adaptations of this curriculum. So we are just incredibly excited about that. And then that leads us into our Intergenerational Harm Reduction Summit. So this is coming up here in August, and we'll be able to get you all a flyer for that today. And this is going to be all things harm reduction across all generations, harm reduction the Indigenous way summit. We'll have 2 components. It'll be either virtual or in person. So we're doing a hybrid, folks, and everyone is invited to join. We've got some really exciting speakers. So we've got some speakers who are talking about harm reduction and sex trafficking and messaging for sex trafficking survivors. We've got some folks who are talking about harm reduction and of course, like, what do we call it? Intergenerational strength. I know we typically talk about intergenerational trauma. And so now we're going to really flip it on its script and talk about intergenerational strength and intergenerational success and how to have that healing aspect, but more than that healing aspect, that thriving aspect. And then also we'll be having some folks who are discussing things like mental health, land and food health, medication safety. So all things harm reduction, but with it through an intergenerational Indigenous lens. And then last but definitely not least is the United Indian Health Services is coming up with some is currently doing some sweats, but we currently do them in an inepi, which is not necessarily part of local tribal traditions, but they're still great. So we currently do sweats and steams in the in inepis, and United Indian Health Services is building 2 sweat lodges and a house. These are going to be used for dances and ceremonies. So sweats for folks who are identify as male and steams for folks who identify as not male or women. And also the house will be used for ceremonies such as like dance demonstrations and other things. Amanda, is there anything you want to add about sweats?
That's great about the sweats. I was just going to share the houses are a Yurok house that was taken from Sumig State Park. So this is something that's already been built, and a lot of the more inland hoopah houses look like this too, where you kind of crawl through and then it opens up to a pit in the middle. And so this won't exactly be what it looks like here at UIHS. So just kind of giving you an idea of what Northern California tribes look like when they build their houses and lodges traditionally. However, like we said, we work here at Pottawa, it's on Wiyot land, and so we always acknowledge that we are working on Wiyot land, and they have some houses. Every tribe has some different, depending on where the location is in Northern California, what kind of wood's used. So some have more driftwood that are more on the coast, and some more inland have cedar, and some who are along the coast ridges have redwood. And so really, because UIHS is a component of all different tribes, we have a group that's coming together that are some elders and some local knowledge keepers from all the different tribes to talk about what our sweat houses will look like. So it won't look exactly like this. This is just something that's already being used by the Yurok tribe, but it will be similar. There'll just be some different, some little differences in the specifics, but what I really liked about it was that everyone kind of has a voice at the table, and it may take a little bit longer, but everybody's opinion will be a part of it. So that was great. And this might be our last slide. Is that right? Because it's our future. Yeah. So those are the things we've done leading up till now. Questions?
Thank you for that. You really have done quite a lot. That's very impressive, considering all of the constraints that the COVID pandemic put on everyone. I just want to check through the chat and make sure that we've covered. Robin did put the link for where they order their fentanyl trust scripts in the chat. It's back up at the 139 mark. You mentioned in your presentation that, and I had missed this, that President Biden made the entire month of August Overdose Awareness Month. Is that correct?
I believe so. I think that's what I remember. Because yeah, I knew that because we'd been celebrating just that one day, and but because we were leading into the one day and getting all the huckleberries out, like the whole month of August had been that, and so we were thinking, like, when he proclaimed it, I was like, oh yeah, we think that too. So, and then when we were planning the harm reduction summit, we want to plan around it again. So that summit will actually be the day before, the day of, and then September 1st, like leading into the Suicide Awareness Month. So,
and then October is also, or September rather, is also Recovery Month. Correct, Paul?
Perfect.
Yeah, SAMHSA will have a whole series of events for Recovery Month as well.
Hi, Amanda, Chelsea, and Robin. Did you find between tribal communities, was there, when you talk about integrating culture, did you find that the various tribal communities had similar ways of addressing that, or were there some unique differences in terms of thinking about activities related to harm reduction? I was just curious.
That's a good question. I mean, many of our local Northern California tribes are very similar just in general. There's little differences sometimes based on mostly region and what's available. But then a lot of us, like myself included, are a combination of a lot of different ones. And so a lot of things get integrated. I don't think there's like any difference where people are like, this is like a real big thing that's a challenge, but I think everyone just kind of has their own voice to add. And so being able to just like have everybody's voice added in helps kind of create a better whole. I don't know that we've really run into anything that kind of one person is like, you know, really set against something and another person is opposite. So we haven't had any of those types of interactions. It's mostly just everybody kind of lending their voice and their perspective. Which is cool. It kind of creates something that's more inclusive just in general too. So inclusive of so many other people, it helps it be a more broad understanding. Yeah, so harm reduction, you know, it's interesting because yeah, harm reduction has its own kind of stigma, but really when I start thinking about, you know, coming alongside somebody, hoping for the best, expecting the best, being a good family member, right? Like harm reduction to me is kind of the native way. It's kind of the native way prior to colonization. And so really like, we don't necessarily even have to use, say, the term harm reduction. We just talk about it as far as like cultural strengths. And so even when we're talking about like a harm reduction summit, the intergenerational thing came from, it was just during a discussion of a presentation on intergenerational trauma. We were talking about how if that's there, we also have like our own strength and resilience to know how to overcome it and to be able to start encouraging from generation to generation where the strength and resiliency is, so that we can draw on like it's wisdom at that point because there's experience behind it. And so really it's just kind of like our own traditional ways instead of harm reduction, because I really feel like it's pretty synonymous as far as meeting people where they're at. And even with ceremony, everyone can come. You might not be able to be a leader because you have to be in a good way and have a good heart, but you can be there. And so that to me is just inclusive of everybody where they're at. Trying to, is it just in practice or more diverse in stories? What are you referring to?
Oh, you're talking about the similarities and stuff with multiple tribes.
Yeah, so practices for sure. We all have similar dances. So we have like brush dances and jump dances. And we were just talking about this yesterday with a presenter. So right now we're it's like brush dance season, and it's for healing. It's usually for healing of children in the family, or just for health in general. But different tribes have different, say, animals that are kind of more important or signifying the strength or determination, or kind of the lookout of that dance. So some of our cultures, some of the men as they enter will be more like a woodpecker, and some kind of fly more like an eagle. And so depending, and those to me are like where they are regionally, and what animals are more predominant, the leaders in those areas. And so they all work together, but they do have their own distinct, I guess, parts to it. But together the whole thing could look the same. Like the brush dance could look the same to anybody that's looking out, but the people who are part of it know that they're representing something different in those moments. But it's still for the same. It's still for the healing. It's still for the healing of the child. So it seems like that where they actually do go together pretty well. It's just maybe a different perspective of the same thing.
Oh, that's really good. Yeah, I noticed like, I'm not sure how it is there, but I know like in the north, kind of east, they place a really strong emphasis, like mid to the east anyway, really strong emphasis in the bear. I like how powerful it is, how much you can get healing from and stuff like that. But in some areas of the United States too, that there are those that are more afraid of the bear and its energies and stuff like that. So I know something like that can cause some kind of anxiety, and even the anxiety about it can make them sick or something. So
That's interesting. Yeah, the bear, for instance, I think is mostly just kind of revered and respected. I don't know many people that would maybe be super afraid of it. I mean, honor it, and but it's like definitely more like a family member, I think, mentality towards the bear. Yeah, I personally have way more fear of a mountain lion than a bear.
We actually have mountain lions in Iowa,
You do.
although I think we should call them prairie lions if they're going to be living here. But yeah, we've had several sightings, and I agree, I'm more afraid of them than I am of a bear.
Yeah, I've been in the woods with a lot of different animals. It's the only one that like makes my hair on the back of my neck stand up. Thanks for the question.
You mentioned stigma attached to harm reduction, and I'd be curious to find out a little bit more about that. We've obviously encountered a lot of stigma attached to MAT, but harm reduction, is that because you're not promoting abstinence there?
Like stigma to I think it's just mostly lack of understanding of what it means, and thinking like maybe it just to one person means just MAT or just syringe exchange, or, you know, where it's kind of this thing where it's more of they think of it as more enabling than helping. And so honestly, I think the main difference is just a lack of understanding of what it really could look like practically, and then having kind of an idea in their mind of what it maybe had been presented to at some point, and previously what they thought it was.
So how do you address that?
Mostly just education, having open discussions of what it could look like, and answering questions in a way where they feel comfortable to continue to ask about it, and kind of being like people like Chelsea and Robin, and when we're out, just people that they know they can come and talk to about it, and get more information without, I guess, judgment either way. Judgment for asking or judgment for not knowing. I don't know, Chelsea or Robin, if you guys have any other things to say about it.
I agree. I think it's just, yeah, when you have like naysayers who are kind of more abstinence only based, you know, just hearing them out, and then explaining in a kind way what harm reduction is and why it works. I think a lot of people don't realize that harm reduction isn't just like, here's a syringe, okay, bye. That there's this whole other aspect of it, of, you know, being there for people where they're at, and of really being open and warm and welcoming and providing resources and things like that. And I think there's a, in general in our communities, I would say in Humboldt and Delaware County, there's a really negative stigma against folks who are in the houseless community, and that might get conflated with harm reduction, just in our community specifically. I don't know if other communities have that too. But really, we just say we're here to help everyone and help everyone where they're at.
I forgot too, one of the things that we started doing, and Robin's been a part of this, and another specialist, is everyone who gets who's employed at UIHS, as they go through their new employee training, gets a Narcan training, and then it's followed with a harm reduction discussion right afterwards. So just what that looks like and what that can look like for care. Because honestly, the more I've begun to understand about harm reduction, the more I realize it's not, you know, it's not just Narcan, it's not just one, it's not even just opioids. Like it spans and goes across our entire health promotion and education department now, because it can be in physical health, it can be with sexual health, it can be with LGBTQ and Two-Spirit, it can be just harm reduction, just coming alongside someone and meeting where they're at, and being able to be, you know, a presence for someone even just while they're figuring out their pronouns or whatever that looks like. Harm reduction is way more than just one thing these days. And so we really, like our department tries to focus on just bringing that to all different parts, every grant that's a part of us, figuring out ways to be more inclusive and yeah, just opening and engaging with people.
I've learned from other tribal communities that when they have a peer support specialist program, that they're the best communicators about harm reduction sometimes. So I think just having a peer support person in the community, living life and being willing to share their story while they're helping other people, that makes a huge difference. Just across the country, I hear that more and more, just as an aside. Looks like Charles and Sean are having a conversation about animals.
Cool.
Do you all see more resistance to like the fentanyl test strips maybe than the like MAT and Narcan naloxone? And going back to MAT, one of the things we're going to be talking about at our harm reduction event later in August is, you know, you hear it referred to as treatment, harm reduction, and recovery. You know, for some people it's recovery. So, but yeah, I agree. In my experience, education is the key, and emphasizing that, you know, it saves lives, reduces harm, there's cost savings, tremendous cost savings, like syringe service programs and some other strategies. And like you've been saying, it's an opportunity to connect people to services so that if and when they're ready, they know who to reach out to. And that there are studies that show that there's a much greater likelihood of someone finding recovery or other services they need if they encounter kind of harm reduction programs. But I was just curious if you see kind of different resistance to the kind of different main strategies out there.
Yeah, first of all, that reminded me that the medication assisted recovery is something that our behavioral health department did change their verbiage to be is recovery instead of treatment. The medical side hasn't yet, but the behavioral health has. And yeah, I think that originally, so when we were presenting some of, say, the test strips and stuff in the community, a couple of times, people were like, I don't need that, and kind of I think we're just pushing it away. But I think more and more, and especially throughout this last year or so, enough of our local tribal communities have lost people to accidental overdose. Like we have like the Park 30s and stuff go through with our kids. And so we've seen youth accidentally overdose. And so with that has come a lot more, at that point, it's not a point of like whether you're going to look down on it or not accept it. It's that people see the value for needing the help and needing the support and needing the education. And so when you're seeing your kids go through that and then have to deal with the after time, they just want as much help as they can get. And so that kind of has helped, I guess, and not that I wish it on anybody, but it's definitely changed the dynamic of how people receive it when we're out. Now we've had one of our local tribes had like a drug protest because of the amount of drugs that were on the reservation lands. And so now when we're out, we have people that are actually thanking us. They aren't acting like they don't need it anymore. They're just very thankful for it to be there. It came through hardship though, so it's not the best way.
Side note on that too, I feel like one of the like weird strategies I got from outreach that I feel like really helps is I offer it to everyone, and I offer it always as if you or someone or you or someone because then that gives people a little bit of an out, like I'm not calling you out. And then I feel like I noticed the second that someone who maybe the community perceives maybe doesn't utilize substances takes fentanyl test strips, I feel like it gives everyone else license to. And so I feel like I've noticed that like a couple really cool community partners and a couple of our community health representatives have come up to me. And then after they've come up to me and gotten stuff, then everyone else is like, oh, it's okay, I can get these too. Or I hand them with some, I don't know, little strategies like that to reduce the stigma. And that's not me doing it. That was like a community health person, coming up.
Have any other comments or questions?
Steve, do you want to talk about your comment?
In the chat, Steve asked if there's any interest and or discussion about low dead space syringe access for IDUs.
Sorry about that. My headphones were cutting out and I didn't hear that prompt. Yeah, I didn't know if that was something that there had been any discussion or awareness about as a sort of additional harm reduction measure in the low dead space syringes.
I'm so sorry, Steve. Can you define low dead space syringes? I'm pretty new to tribal opioid response, and
Yeah, no, it's something that I learned about in the last 6 months. There are syringes that compared to a traditional syringe, there are syringes that literally have very, very small, what they would call dead space or extra space in the cylinder, so that it would reduce bloodborne disease transfer, and they are available. They're just not widely used and distributed. But there's variations of it. The very lowest dead space syringe can reduce infection rates substantially. And I just don't know if that's something that has come up in any discussions. It doesn't sound like it, but it's sort of another harm reduction measure within a harm reduction measure. If I can provide clean new syringes with low dead space, I'm going to reduce the disease transfer, bloodborne disease transfer for intravenous drug use. Anyway, just something I wanted to throw out there.
Yeah, that makes a lot of sense. It's really good. I wrote it down. I'm going to look into it some more. We did a syringe exchange prior to COVID, and when COVID happened, the clinics that were more successful with it closed down, and they haven't really been able to create space for that to happen again. So we haven't been doing syringe exchange these last 2 years, unfortunately. So we're not as well versed in the new strategies of that. Keep looking for different funding so we can keep that going. Also, we need space in some of our clinics so that it can happen.
Any other questions or comments?
I really like the comment in the chat about language and including language and body language as harm reduction and as a very important part of everything. So thank you for that. I agree.
I really like your concept of intergenerational strength. I may steal that.
Definitely is not mine. So I did not come up with it. I am passing it along, so I cannot take credit. But yes, I think it's a good thing to talk about, intergenerational strength. We're having I think some people might know him, a very, very, very wonderful gentleman named Albert Tidman, who is going to be presenting on that. And that is something that he discusses and is a proponent of. So give credit. I want to give credit where credit's due.
Well, hearing from Maria Braveheart, I mean, we need to like look more at intergenerational trauma as more of a symptom and how to move past that. And a lot of times it's in healing, but there's also strengths, and some of those strengths can also be like even ceremonies and how you get past those things. Because, you know, a lot of times when we look at harm in a sense that we do to ourselves, even emotionally or psychologically or anything like that, I mean, a lot of times when you look at PTSD and different traumas, it does matter how we think about it, because the thought comes before our emotions and feelings. And that's the real kind of space to be able to hit that, because nobody can really make somebody feel shame or guilt. I mean, it has more to do with the person who's thinking and looking at like cognitive behavioral therapy and things like that. So, and cognition, but moving past that trauma and looking at strengths and healing efforts and stuff like that, I think is a really good way to go. It was not something that you keep showing all the harm and trauma done, because actually if it goes too long, I think you're re-traumatizing the people anyway.
Yeah, I agree. The re-traumatizing, and I think that I think I learned that from Katie Bell about stigma, that there's stigma injury. Like you have like the injuries and then you have other injuries that happen afterwards. And so then you're combating like layers. And so yeah, I think it was Albert that was talking about it, and it just kind of had this like moment in my brain where it's like, yeah, we have that in our past and linked between our generations. We also have the ability to access that grace and that strength and that wisdom. And so yeah, maybe making it through from generations to not have more re-injuries would be great. Even part of harm reduction, right? Because a lot of us grew up with people who either ourselves or our family members or very close loved ones have been in and out of recovery. And so, you know, when you're really little and you're growing up and seeing it, and then you're kind of coming in this program where you're like, man, this is something I've already been through, but now you're saying like, we're going to just support them. And so there's a lot of just things to be conscious of and sensitive to, I think, on all levels, but definitely the outcomes are well worth kind of pushing through a little bit. Yeah, the goods are outweighing the harm when it comes to, I think, harm reduction.
So if there are no more comments or questions, then I would like to thank Amanda and Chelsea and Robin for joining us today and sharing what they're doing. It's really amazing, very impressive.
Thank you. Thanks for having us. Thank you all for being here.
Thank you.
You are welcome to stay on. Right now, we're going to take a break. And when we come back, we will do breakout sessions and our GPO updates from Paul and the usual closing. So if you can join us, we hope you can join us. We will be reconvening at 45 minutes past the hour. Thank you again to United Indian Health Services, and best of luck to you in your many, many projects that you're aiming to help your communities with.
Yes, thank you again. That was great.
Yeah, thanks. I do have to step away, but it's great to be able to join for this.
Well, thank you for making the time for us today. It's fabulous.
Yeah, of course.
We are going to put, for those of you who have to leave, we are going to put the GPRA link in the chat and respectfully request that you fill it out, because that's how we get better. And for those of you who can stay on, we will see you in approximately 14 minutes now, at 45 after the hour. Thank you all.
People to share their thoughts or feelings. And we could do that by you turning on your camera and mic, which is preferable so everybody can see and hear you, or if it just doesn't work out, to put a comment in the chat box that we can monitor and share. One thing I could share with you as I was listening to our speakers is I kind of noticed how they started with kind of prevention activities, kind of more traditional public health strategies, focusing on awareness raising, and just the posters that they shared pictures of with us. I think that was year 2. They started to move more into an integrated approach, bringing in the medical staff and the counselors. And I just thought that was interesting. That, you know, it sounds like they had a pretty good plan. And the amount of things that they were able to accomplish were pretty impressive, given that their area covers lots of different tribal communities. And it sounds like it was pretty well received. But that was something I noticed, that it's always kind of a stretch to get the integrated approach. And I think with things like medication and the overdose issues, the concern for young people and our elders, that they took a kind of a systematic approach to addressing that, and it shows in their products and their outcomes, and that was pretty interesting. And it could be duplicated too across tribal communities, possibly. So that was a nice to hear what they were doing with their grant monies. Those are my thoughts.
They gave such a great presentation that they answered all questions. And
I guess I'll break the silence. Yeah, my observation is just that they're one of many grantees we have that really take advantage of the flexibility that the TOR grant offers, because you can do everything from prevention, treatment, harm reduction, recovery support, you know, and they're doing basically everything. And grantees can focus on one of those areas exclusively or all of them. Yeah, we're hoping to get into this later, but with this latest round of TOR 2022, tried to elaborate more on what is allowable under in the areas of harm reduction and recovery support. You know, we haven't seen the specific proposals yet, but I think we have about 100 and, you know, over 100 applications. So we got a strong number, and I'm looking forward to seeing what kind of innovative project applicants put forward.
Paul, it seems like education, community education, and provider education has been a common theme in recent presentations that we've seen. Do you have any insight or advice on incorporating those educational components into your grant?
Well, yeah, like Amanda said, I mean, education is so important, especially when you're, confronting beliefs, stigma that's just not rooted in fact. And that's everywhere. I'm on a volunteer board in Arlington County where I live, the community service board. We oversee behavioral health functions. And yeah, the community outreach, not only distributing, the tools out there, the Narcan and the fentanyl testing strips and things like that, but, producing the educational materials, flyers about it, and at those live events, having the opportunity to talk to people one-on-one about why we're doing what we're doing, what harm reduction is, what it isn't. Again, the fact that it saves lives, it reduces suffering, saves cost, and provides connections to services and personal connections. And I really think with peers and people with lived experience, the most powerful tool I think you can have is to have someone with lived experience who encountered harm reduction services and later, reached out and got treatment and has found recovery. Those to me are the most powerful stories and the best way to overcome, the stigma and the resistance that's out there. But community outreach is definitely a key part of it. And then that whole public awareness around these strategies, about not using alone, making sure you have Narcan, staggering use, things like that. I mean, that not using alone piece is real important, because someone uses alone and it doesn't matter how much Narcan they have on them, can't help them.
I know it comes to mind when it's looking at opiates is kind of similar with methamphetamine in treatment. A lot of times I've seen counselors or professionals who have a stigma towards some of those users. And I know with opiates, I used to hear a lot like, oh, they're not feeling pain, they're just, it's all in their head, and with methamphetamine, a lot of times, oh, they're paranoid, and that's why they're hearing these things, and their fear is not real and stuff. But I began to look more at taking care of crisis at the point of a client or patient, because when you look at crisis, not everybody handles crisis the same way, and that a lot of times their level can be higher. But I began to teach more with the other professionals is that it's not always what they think it is that methamphetamines, when these people are out there buying drugs or methamphetamine, they're going into these houses and you might see a knife or gun or something like that in every room of the house. It's nothing to laugh at. That's real. That is serious. In their mind, they are worried for their life. And when you're looking at opiates, they do feel pain. It's just that the way that the chemicals and the brain has adjusted these chemicals with neurotransmitters and stuff like that is some are shut down, some are lowered, some things might be raised in changing and stuff. But over time, neurotransmitters within the brain and body, they do change over time. So the more somebody is putting substances in, such as, opiates to overcome pain, the more sensitive they also become. And that's something that they also need to look at with stigma and harm reduction. So I think that's really important.
And then you add trauma on top of it, Sean.
Yeah, yep, definitely.
The stigma around harm reduction is really interesting to me. And Paul, we were talking a couple of weeks ago, and you mentioned.
I had one, I couldn't go that day. Remember?
Oh, I'm sorry. Did you want to say something else?
I'm sorry.
Paul, you had mentioned that a bar is really a harm reduction mechanism, which, I never thought of that. It's a safe consumption site. And that equates to, it's a safe consumption site for alcohol. And why is that different than a safe injection site? And the only thing that I can think of is that alcohol is legal in most areas of the country. There are still some dry counties here and there, but injectable street drugs are not. That's the only thing I can think of that would attach that stigma to that harm reduction measure.
Yeah, I think that's the primary difference, certainly. And I saw something recently called, this is harm reduction. It had all these different things that you wouldn't necessarily think of, like bars. But yeah, I mean, if you think about how many people, they get cut off, other people insist that they get a ride home. Certainly a lot of harm reduction there of preventing people from hurting themselves and others. But yeah, we're not, at least in this country, we're not there in terms of safe consumption sites for other drugs. But it is spreading in other parts of the world, and I suspect it'll be here it is here, just obviously not formal or legal, but there are places that are providing that, just like they did with syringe exchange, syringe service programs for many years before it was legal anywhere.
I don't know if anyone in this group has run into issues with fentanyl strips. I saw something not too long ago that said that some states have carve-outs in their drug paraphernalia laws that allow fentanyl testing strips, but other states do not. And so that's a big barrier. If it's illegal, not only to have the drugs, but to have the test strips to see if they're laced with fentanyl, that's a barrier to using them and a barrier to the grantees to providing them to their communities. I don't know if anyone in the group has run into that. It sounds like for this group, a big challenge might be finding a supplier for the test strips. It's a quiet group today. Shall we move on to the GPO updates?
Yeah, that's fine with me. I mean, and even syringe exchange programs are still legal in some places, but where that's true, for the most part, it's not enforced. So there's always that issue of it might still be legal technically on the books in the law, but is that where law enforcement is spending its time? Hopefully not.
It makes it difficult to collaborate with law enforcement in that situation.
That's true.
Well, if no one has anything to add, we'll let Paul share his updates from Samsung.
Do I need to swap the screens or do you see the right title screen?
We see the title screen.
Awesome. And just let me know when to forward.
Thank you, Parker. Take it away, Paul.
Okay, can you hear me now?
Yes.
Okay. Yeah, you can go ahead and advance the next slide. That's me. All right. So got a few things coming up in the grant cycle here. We're coming up to the end of the cycle for the TOR 20 grantees. So if you're one of those and you still have money, funds to be expended and will not be able to do that by the end of the project period, you can request a no-cost extension for up to 12 months. The request for no-cost extension must be submitted no later than 60 days prior to the project period date. So that's the end of this month, July 31st. The request must be submitted through ERA Commons. If there is no cost extension submitted, then the project end date is September 29th, the end of the fiscal year 2022, and the grantee should prepare for closeout. We will be issuing guidance via email with details, instructions, and resources. All right, next slide. Closeout. Okay, I have not gone through closeout myself, so I'm basically going to read this. The project period for the FY19 TOR grants ends on September 29th, 2022. Actually, that's for TOR 22, TOR 20, sorry. Grantees who will not be submitting no cost extension should prepare for grant closeout. Recipients must complete all actions required for the closeout. And then there's a list there. Reconcile financial expenditures, liquidate all obligations incurred under the award by December. So you do have a couple more months, October, November, December, to spend down funds. Submit to HHS payment management system the final quarterly federal cash transactions report, and return any funds due to PMS as a result of refunds, corrections, or audits. Complete and submit 3 required reports no later than 90. It says 90 and 120 days. I think it's 120 days. Brittany may know after the end of the award, so that these are your other ERA items: the final financial report, progress report, and the tangible personal property report. Brittany, do you know which one that is? She's still here. I closed out the box for people. Okay, next slide. Gipper SOAR TOR program instrument. Okay, you've probably seen a few different emails on this. This is the part of GIPRA that where we collect data, where you answer questions on the lock zone. It used to be just a 3 questions on the lock zone. Again, this only applies to, you only have to answer these questions if you're using TOR dollars to purchase the naloxone and now the other, the test strips and other questions, other related questions on there. So it used to be just the 3-question tool. It's switched as of April 1st, the second quarter of the fiscal year. So for April, May, June, if you're using TOR dollars for naloxone testing strips, some of the other things on there, you should answer the questions in the program instrument, which is on SPARS, which is how we collect our GIPR data. So yeah, then there's a little more information here. The updated instrument, it used to be 3 questions. I think now it's 12. So we're looking for data, if possible, on overdose reversal based, on the Narcan that you sent out. I know it's going to be hard to know that in most cases, but you may have some data on it depending on the sources of who you distributed the Narcan and naloxone to. Fentanyl test strips purchased, distributed, education of school-age children, first responders, key community sectors on opioid stimulant misuse. That's kind of prevention related. And then outreach activities that target underserved and or diverse populations. Okay, next slide. A little more on that. Client data collection is required for all clients receiving treatment or recovery service. Okay, this is the other piece of SPARS, the client level for people who are in treatment. It's not required for prevention activities, data collection. These are the questionnaires, baseline at intake, 6 months follow-up, and then at discharge. 6-month follow-up interviews are required for every client, regardless of discharge status. And again, that's all gets downloaded into SPARS. Recording and supporting documents are available on SPARS. Okay, next slide. So we've been working to try and streamline this. The questionnaire was pretty lengthy, took a lot of staff time, some other issues. So it went through the Federal Register process, kind of similar to what a rulemaking goes through, and so that the questionnaire has since been streamlined somewhat, and the new tool, the new questionnaire, will go into effect October 1st of this year. There was apparently an email sent out June 23rd explaining the changes, and if you have any questions related to that, there's an email included there, and you can also, of course, reach out to your GPOs. All right, next. This is the latest. I don't think it's new anymore, but with the new contractor, Mathematica, this is the current toll-free number for the SPARS help desk, as well as the email for the SPARS help desk. And they're pretty good about turning around, creating a ticket number and getting issues resolved. All right, next slide. Recent upcoming TOR webinars. You can see the list there. And again, as we discussed earlier, you can go back and view the recordings. One thing I wanted to mention on the no-cost extension, since I learned this kind of the hard way this year, because I had a grantee in a no-cost extension. Once you're in a no-cost extension, you cannot do kind of any major change of scope to the project. It's basically you have extra time to finish implementing your project, but it's not, major changes are not allowable. I mean, there's always going to be minor things, but the expectation is that you'll just finish out your grant project. All right, next slide. TOR grant conference calls. Hopefully you all are having these with your GPO, at least on a quarterly basis, to discuss just how things are going, problems, successes, any issues with spending, GPRA and SPARS, and any of the items on that are required through ERA. We have a great staff that helps us on the grant management side, who can help with, the ERA submissions and any kind of spending budgetary issues as well. All right, next. Okay, any questions? And here listed here are myself and Will and Brittany, the 3 GPOs currently on the TOR grant. So I think that's it.
Thank you, Paul. Any questions for Paul while you have him as a captive audience here? Or Brittany?
Oh, and also we'll be sending out we're doing just a quick 2-day kind of harm reduction summit, August 3rd and 4th, just OTAP. So obviously we're inviting all our grantees as well as folks through other networks that we have. We're just actually finishing up the flyer today, so keep an eye out for that. It's an all virtual event, 11:30 to 5:30 for each day to accommodate our friends on the West Coast and Alaska.
That sounds like it'd be really interesting.
Yeah, the bulk of it, the main focus of it is, people from the communities who are doing the work. But we have some good kind of, I guess, additional speakers before our panel on MAT. Our director of CSAT, Dr. Ingvild Olsen, is going to talk about MAT and its efficacy. And then that will lead into a panel, just like with all the other topics, a panel of kind of practitioners, subject matter experts on the ground that are working with tribal communities.
And when did you say that is going to be?
August 3rd and 4th.
So
You'll probably see
coming
that.
up
You'll
pretty
probably see
fast.
the flyer before the end of the day today.
Oh, that's okay. Any other questions or comments for Paul or any of us at the TTC or for each other? Well, we appreciate you all joining us on this summer day. If there are no questions or any discussion that you'd like to have, then as my gift to you for July 19th, I'm going to give you back almost 45 minutes of your day. How's that? Would anyone like to offer a closing blessing or way to send us off in a good way? And I will thank you again for your time. And wish you all well until we meet again. Thank
Right.
you, everyone.
Thank you, everyone.
Bye.
Great day.